On about thyroid eye disease. So what are the typical ocular changes in thyroid eye disease? They are lid retraction, lid lag and proptosis. It is also known as endocrine exophthalmos, that is proptosis, this thyroid ophthalmopathy, ocular grape disease, Graves ophthalmopathy and thyroid associated ophthalmopathy. So about etiopathogenesis, risk factors and pathogenesis. It can be associated with either hypothyroidism or euthyroidism. 90% of the cases are associated with hypothyroidism, 4% of the cases are associated with hypothyroidism, and 6% of the cases are associated with euthyroidism. What are the risk factors? Middle-aged female, smoker, who has autoimmune thyroid disease, and it is associated with HLA-DR4 and HLA-B8. About pathogenesis. So it is considered as autoimmune disease. So the primary target of the autoimmune process is orbital fibroblast. It is not extraocular muscles. Extraocular muscles are secondarily involved. So this is about thyroid follicle, fibroblast, and thyroid follicles may share similar antigens, and T cells stimulate fibroblast and adipocyte lineage. So as a result of this, there occur adipogenesis, fibroblast proliferation, glycosaminoglycan synthesis. So due to this, as a consequence, there occurs edema and cellular infiltration. So due to edema and cellular infiltration, extraocular muscles are enlarged. So this is secondary. First is orbital fibroblast, which is the first affected muscle, inferior rectus muscle. So there is a mnemonic, I am slow. Inferior rectus, medial rectus, superior rectus, levator, lateral rectus, and oblique. So the source is American Academy of Ophthalmology. So due to this, there is diplopia. Inability to look up when eye is adducted, means inferior rectus is involved, medial rectus is involved. So inability to look up when eye is adducted is known as double elevator palsy. So first let's look about clinical features. So thyroid eye disease typically has a progressive inflammatory phase followed by a stable post-inflammatory phase. So this gives a Rundle's curve. So this is a Rundle's curve. First inflammatory phase, also known as active phase, it occurs 1 to 3 years, and after that there is inactive phase, 3 years, and later fibrotic phase. So the pattern of the disease follows Rundle's curve, which describes the plot of orbital disease severity against time. Initial phase, inflammatory phase, and after that there is quiescent phase. There is gradual improvement with improved motility and retraction of muscles. So what are the signs and symptoms? Upper eyelid signs in thyroid eye disease include: first, most common and earliest is Dalrymple signs. So retraction of upper lid that gives frightened appearance, also known as Dalrymple sign. Stillwalk sign, incomplete and infrequent blinking. This is infrequent blinking. Gifford sign, difficulty while everting the upper eyelid. Jelinek sign, abnormal pigmentation of upper eyelid. A lower eyelid sign in thyroid eye disease include Inorth sign and Griffith sign. Inorth signs mean lower eyelid edema. Griffith sign means lid lag and off gaze. What are the conjunctival signs? Gold-Zahir signs, that is conjunctival injection, that is deep conjunctival injection, and chemosis, that is conjunctival edema. Extraocular movement sign include Mobius sign, that is convergence insufficiency. Ballard sign, one or more extraocular muscle restriction. There is a term called restrictive ocular myopathy, we will come that later. Zucker sign, poor fixation in abduction. Gendrasic sign, paralysis of all extraocular muscles. Note that the most common ocular motility defect is unilateral elevator palsy. So I told you that previously, inability to look up when eye is adducted, that is known as double elevator palsy. But the most common ocular motility defect is unilateral elevator palsy due to involvement of inferior rectus muscle at first, followed by failure of adduction due to involvement of medial rectus muscle. Inability to look up when eye is adducted, that is known as double elevator palsy. So the first is unilateral elevator palsy followed by double elevator palsy. The eyeball may be deviated towards the action of involved muscle. Note, this is very important thing. Example, if medial rectus is involved, eyeball deviated medially towards the muscle involved with restriction of abduction in spite of lateral rectus being normal. So this is known as restrictive ocular myopathy. In spite of lateral rectus being normal, the eye is deviated medially towards the side of affected muscle, that is medial rectus. This is known as restrictive ocular myopathy. So what are the pupillary signs? Needs sign, uneven pupillary dilation in dim light is known as Needs sign. Cowen sign, jerky contraction of the pupil to light. Generalized sign, Geoffroy's sign, absent of crease of forehead in looking up, that is superior gaze. So how can you remember two important signs, Von Griffith sign and Von Graffi sign? So in grief, if you have grief, you look towards the god, to the sky. In grief, you look up. So lower lid lags on looking up, that is known as Von Griffith sign. While looking down, Von Graffi sign, that is upper lid sign. So Von Griffith sign is lower lid sign, Von Graffi sign is upper lid sign. What is the second most common sign? First most common sign is Dalrymple sign. Second most common sign is exophthalmos. As a rule, both eyes are symmetrically affected. One eye can be prominent than other. Even unilateral proptosis can occur. Thus, Gray's ophthalmopathy is commonest cause of both unilateral and bilateral proptosis in adult. So how can we classify? According to American Thyroid Association, there is mnemonic no specs, NOSPECS. No signs and symptoms, only signs, no symptoms. Lid retraction, with or without lid lag, mild proptosis. Yes means soft tissue involvement with signs and symptoms. What are the symptoms? Lacrimation, photophobia, lid or conjunctival swelling. So in proptosis, the cornea is continuously exposed to the environment and there is infrequent blinking. So there may be lacrimation, photophobia, lid or conjunctival swelling. P means proptosis well established. E means extraocular muscle involvement. C means corneal involvement due to exposure keratitis. So I have told you the reason. Slight loss due to optic nerve involvement, disc pallor, papilloedema, visual field defect. This is due to the optic nerve involvement. So in exams, you can write class 0 to 6, 0, 1, 2, 3, 4, 5, 6 and the way is no specs. So what about the clinical course? It is self-limiting disease, course of about 1 to 5 years. It lasts longer in smokers. There are two phases, active phase, inactive phase. So I have already told you about the curve. Active phase is inflammatory phase, fibrotic phase or inactive phase is quiescent or burnout phase. So in this phase, eyes are white, however a painless motility defect may be present. Motility defect may be present and it can be painless. So what are the investigation? Thyroid function test, T3, T4, TSH, serum T3, T4, TSH and radioactive iodine uptake estimation. Thyroid antibody assay, anti-TSH, anti-thyroid peroxidase, anti-thyroid globulin and thyroid stimulating antibody. In USG, it can see defect in class 0 and class 1 even. So it is for early diagnosis. What is the hallmark? Extraocular muscle involvement, extraocular muscle enlargement without enlargement of extraocular muscle tendons. In CT, you can see proptosis. You can also do MRI, T2 weighted and STEER. So this is globe and this is orbital part of optic nerve. So if you have proptosis, then the orbital part of optic nerve is straightened because the length of optic nerve from posterior pole of the globe to the orbital apex is longer than this distance. So it is accepted normally. But if you have proptosis, then this knob is straightened. So what are the treatment? Treatment modalities include periodic clinical workup, non-surgical measures and surgical measures. Periodic clinical workup. You have to do clinical activity scoring. It has 10 features. Dolor, rubor, tumor, functio di lisa. These are the signs of inflammations. So pain has 2 features, redness has 2 features, swelling has 4 features and loss of function has 2 features. You give 1 score each and you do clinical activity scoring. And another is ocular motility workup. And non-surgical measures include smoking cessation, head elevation and at night, and cold compression at morning. It reduces edema. Lubricating eye drops. Guanethidine 5% eye drops. It decreases lid retraction. You can apply prisms for diplopia, and you give steroids to reduce the inflammation. So what are the surgical measures? It can be done in active phase and in quiescent phase. In active phase, the main principle is orbital decompression. Why? For progressive optic neuropathy and for exposure keratitis who do not respond to the steroids. In quiescent phase, you do surgical management mainly for the purpose of cosmesis. So there is a stepwise approach. Orbital decompression, extraocular muscle surgery, eyelid surgery. These are done serially, sequentially. Orbital decompression, 2-wall decompression, 3-wall decompression, and 4-wall decompression. Removal of parts of in 2-wall decompression, floor and medial wall. So it allows the retro displacement of globe up to 6 mm. So there is proptosis, eye is bulging forward. So you have to do a retro displacement by 2-wall removal. That is part of floor and medial wall. You can allow retro displacement of up to 6 mm. In 3-wall decompression, floor, medial wall, and lateral wall part is also removed. So it allows retro displacement of 10 mm. In 4-wall decompression, floor, medial wall, lateral wall, and part of roof. In roof, you remove lateral half of the roof and large portion of the sphenoid at apex. So it allows retro displacement of 16 mm. After that, you do extraocular muscle surgery. Most commonly done is inferior rectus recession. And after that, you do eyelid surgery at last. Some eyelid surgeries are mullarectomy, that is disinsertion of molar muscle. Levator recession or disinsertion